Action. Can folks hear me online?
Yes, we can hear you.
Yeah, Gary, it's good.
I'll be loud enough. Hi everyone. Welcome to today's event, shall I call it? I always try to remind people, dissertation defenses are always thought of as very tense, high pressure moments, but they're really a chance to reflect and celebrate good people doing good work. And today is no exception. So we're really thrilled to be here for Joseph's defense. I'm going to start with a little bit of a background on Joseph, but before I do, I'll just give you the lay of the land for folks who haven't been to defenses in our department. I'll give a short intro. I'll turn it over to Joseph. Joseph will give a presentation for around 45 minutes. Then we'll open up questions for the committee who is seated here in the front row. Then we'll open up questions to everyone in the room or online. Then we will, the committee will deliberate in this room with everyone outside, and then we'll come back to celebrate. I just want to say it's been a real pleasure to work with Joseph over these years. I have a habit on days like this to go back to my notes in the first conversation I had with every candidate. So I have my notes from January 7th, 2022, when I interviewed Joseph. And so much is still true. These are my shorthand notes. Great, thoughtful interview, lots of depth to the candidate. Definitely has been intentional in the pursuit of academic and professional training. I asked him about ideas for thesis work, if he were admitted, and he had thoughtful, detailed answers. This word intentional, I think, is a really important characteristic of your time here. You haven't taken anything for granted. You've been really thoughtful and planned about the work you wanted to do, who you wanted to work with, the experiences you wanted to have. You've had these, you've worked with the Center for the Developing Child, the Pediatric Environmental Health Specialty Unit. Several folks on the committee were just talking about how you brought together this team that included folks on the committee as well as children's in a way that we're all very happy about. So from the beginning, you showed that you were interested in pediatric environmental health, and you really just set your sights on that and never what's the word? Maybe unrolled your sleeves. The sleeves were always rolled up to do the hard work that was necessary. So I just want to say personally, it's just a thrill for me to be here today, and also to see so many folks in the audience and online. For those of you who don't know, Joseph came to us after completing a bachelor's from William College.
Go East.
A master's from that other school, John Hopkins. He had worked with the Green and Healthy Homes Initiative, but I would say most notably, he came directly from a position at the Pediatric Environmental Health Specialty Unit at Mount Sinai in New York. So I see a thread of a theme in New York, continuing to work with those great institutions that we all love. In Joseph's time here, he's won many awards. He won the Harvard Presidential Public Service Fellowship. In 2025, he was named the John Lewis Fellow by the Faith and Politics Institute. Just this past weekend, he won an abstract award from the Academic Pediatric Association, the Joel Alpert Abstract Award. There was also an award from the Joint Center for Housing Studies that Marissa and Joseph collaborated on. But you didn't come here to hear me. I just wanted to give Joseph his props and just say, we're thrilled to have worked with you. We're thrilled to hear what you have to say to everyone today. And the floor is yours.
All right, well, thank you, Gary. So some of you may not know I'm also a minister. So I almost said, praise the Lord, you know, it's in me, but welcome everyone. My dissertation is entitled Healthy Homes, Healthy Kids, Assessing Built Environment Disparities and Solutions Among Children in Boston. And as Gary mentioned, this work is done in collaboration with Boston Children's Hospital and the Region 1 Pediatric Environmental Health Specialty Unit. So as we begin, for everyone on Zoom, thank you all for being here. Please keep your audio and your video off during all portions until we ask you to turn it on, all right? And if you have any technical difficulties, please use the chat. And on behalf of my nephew, Elijah, he says, thank you. So to begin with an overview of our time together, I will first start with the background of the motivation for my work entitled Who Bears the Burden? You then will go through my 3 dissertation aims, which looks at different dimensions of pediatric environmental health burden, following with implications for research, policy, and practice. So in discussing who bears the burden among the built environment in children, it is only fitting that I start with myself. So this is young Joseph at 6 years old. I am the oldest of 7 children born and raised in Augusta, Georgia, which is a small suburban town, well, somewhat small field down south. I am the oldest. This is me with the first set of siblings. And as time went on, my parents had 3 more children, and I'm very close with my cousin who lives in New York City. So as growing up, I was in a working class environment, but I had a great support system and great network. So my built environment was a great place to live and to be in. Also, as I grew up, I was a PBS kid, and I loved watching Mr. Rogers. And as we know, he will always sing, "It's a Beautiful Day in the Neighborhood." Now, Mr. Rogers was focusing on the social environment, but those interactions took place in the built environment, being exposed to the importance of where we live in terms of how we relate to one another. I also wanted to be an architect when I was younger until I learned how much math was involved. And I would draw floor plans for fun. I just loved the idea of housing and cities and how do we navigate those spaces. At the same time, I was a person who was really interested in the civil rights movement, learning about why does inequity exist? Why do inequalities exist, especially for people who look like me? And that these events are taking place in the places where they live. When I was in high school, 2 events really shifted my trajectory in terms of my career. One was the murder of Trayvon Martin when I was in high school. He's only 2 years older than me. And then the Flint water crisis happened when I was a junior in high school. And these 2 events happening in places where Black people and other people were in their built environment, but experiencing inequity in so many ways. And I mentioned my relationship to the built environment because I want you to think about your relationship to your childhood and your built environment. Because no matter where we come from, no matter where we are born, we all have a place where we may play, where we may pray, and where we just go about our day. That is the built environment. And for children, it is essential in understanding how it shapes their health and their well-being. Most people spend about 90% of their time indoors. If we're in Boston, it might be 95% because of the weather. But for children, their physiology and their activity levels are different, which means they have a unique relationship with their environment. Again, I'm particularly interested in housing, and housing has both direct and indirect influences on children's health, such as the physical quality of a space, as well as social factors such as housing cost. And there are disparities based on racialized identity, social economic position, and other neighborhood factors that influence how a child may live and operate in that space. For my research, I use 2 complementary frameworks. The first is called the Structural Determinants of Health Framework, which names the political, economic, and cultural systems that are weaved in our social context. These are factors on the left, such as policies or other cultural values that influence the boxes in red, which I focus on in my dissertation. So that includes income, race and racism, housing quality, and importantly, healthcare access. By looking at these different dimensions, we can then view potential downstream effects, but ways to address those potential disparities while considering this broader social construct. Again, I'm also a person who thinks about what do we do about a problem. It's nice to describe it, but how can we help solve it? So one framework is called the Healthy Homes framework, which is a comprehensive, solution-oriented approach to addressing housing-related health hazards. So rather than looking at an environmental hazard in isolation, such as keeping a house pest-free or keeping it ventilated, a healthy homes approach will consider the multitude of factors at the same time, because this may lead to ways to address these issues in a coordinated manner. So both of these frameworks lay the foundation for understanding built environment disparities and orienting ourselves toward solutions. So why do this work in Boston? I am not from Boston. We know Boston has a great sports history. We know it's known in many instances in our society. But one big thing about Boston is that it is known as a healthy city. Massachusetts falls in the top 10 states of the most healthy. That said, there are still significant disparities based off those structural determinants of health. We see in this map that individuals who are Black males have a much lower life expectancy than people of other genders or races. So situating our research in the place where I'm currently living allows us to think about this localized context in ways to address health for all children. Now, I look at two different health outcomes. The first is elevated blood lead levels or lead poisoning. Now, lead is a heavy metal for which there is no safe level. There are concerns about neurodevelopmental and other cognitive delays that could happen in the lifespan, and there's no safe level of lead. Now, children are primarily exposed to lead through lead-based paint, either by ingesting a paint chip or the lead getting into the air if it's disrupted somehow. Boston is considered a high-risk community by the Massachusetts Department of Health for elevated blood lead levels. And when we look at the prevalence of children within the state who have higher levels of lead, it is disproportionately children who are of ethnic backgrounds. When we think about different structural determinants of health, policies and the legacy of redlining and segregation have resulted in the systematic disinvestment in communities, which may lead to housing falling in disrepair, resulting in lead exposure. So a healthy homes approach considers how do we identify and address these lead-based and other environmental hazards at the same time. I also look at asthma in the built environment, which is a respiratory disease with biological, social, and environmental influences. We all may know someone who has asthma because it is the most common chronic disease in children. But there are disparities among children even in this city. Here we have a map of the emergency department visits for children under 18, and the red boxes indicate neighborhoods where there's a disproportionate level of ED visits. These levels are what we may know as Black Boston, the neighborhoods of Roxbury, Dorchester, and Mattapan. Again, seeing how the structural determinants of health influence health down the line. But having this healthy homes approach allows us to use data to inform both clinical care and community-based interventions. So how do we do this? We can use local data to respond to built environment concerns. So these are the three streams of data that I use throughout my dissertation. The first is the Childhood Opportunity Index, which is a measure specifically for children to understand disparities on different geographical levels. You can look at it on statewide, even down to your neighborhood. And the benefit of this type of data is to get a better understanding of neighborhood burden. We also look at municipal data, such as 311 reporting. So cities such as Boston has a system in which citizens and community members can call if they have a non-emergency complaint. such as a fire hydrant is busted or something else is wrong in my neighborhood. There's been research at Northeastern University with Dr. O'Brien and others who have used this data to connect it to other social outcomes. So connecting 311 data to health outcomes can help us understand how the urban health landscape is constructed and how we move within it. And finally, we have clinical institutions such as Boston Children's Hospital. Every child will have to go to a hospital, either they're leaving when they're born, going for a checkup, or even something more severe. So looking at both primary care, emergency care, and even health home-based interventions allows us to look at different dimensions of clinical care to support continued investment in these programs. With all of that in mind, for my dissertation, I used these three data sources for three different aims. The first aim is neighborhood signals of burden, in which we use the Childhood Opportunity Index and 311 data in relationship to blood lead levels. We then look at thresholds of burden. How does the timing of a complaint being made relate to potential healthcare outcomes down the line, looking at asthma-related ED visits? And finally, from burden to opportunity, looking within a home-based community program of addressing asthma complaints and how it may relate to healthcare utilization and costs down the line. These are my three aims, the official titles. You don't have to read them because we're going to read aim one right now. So aim one is entitled Using 311 Housing Complaints and Neighborhood Opportunity to Identify Pediatric Lead Risk. This is a multi-level study of neighborhood conditions. So the introduction and motivation for this particular aim is that we need to know where lead risk is concentrated within cities. Now, housing age is the primary method of knowing that a home may have lead, because in 1978, lead paint was banned within homes. So if you look older housing, you expect it to have lead. In cities such as Boston, a lot of the housing is old. So what are other ways to look at how can we differentiate? That's a microphone. How do we differentiate this potential lead risk? We can look at other neighborhood factors beyond housing. So here in Boston, as we mentioned, it is a diverse, complex city with different neighborhoods. And within those neighborhoods, we see the construction of different social and built environmental factors that can lead to a child having disproportionate lead exposure. As an example, we have Back Bay here, which is a pretty affluent area of the city. And then we have a census tract in Dorchester, which historically may be underserved and have other social factors at play. The gap we are exploring is how do we look again beyond housing age that impacts lead risk through the Childhood Opportunity Index and 311 housing complaints. So the COI is composed of three different domains that spans 44 different indicators, which is a very comprehensive measure of the childhood landscape. Again, as we mentioned, housing complaints are made in real time, and it allows us to assess what could be happening on the neighborhood level. So by integrating both COI and these complaints, we may be able to improve our ability to prioritize screening and inspection. So again, the goal for this project is to look at the COI and tenant reporting housing complaint burden as it relates to both individual exposure to lead and neighborhood exposure to lead. We hypothesize that neighborhoods that have a lower COI will have both children with an elevated blood lead level and a higher rate of lead within the neighborhood. And that neighborhoods that have a higher rate of housing complaints, we will also see an increase in this lead exposure. We also looked at how does COI modify the relationship between old housing and our lead outcomes. Because again, the fact that a house is old does not necessarily mean they may have lead exposure. So the neighborhood context could intervene. Well, amen. So our study population, we are looking at primary care patients at Boston Children's Hospital who received a lead test between January 2018 and December 2024. Based on our exclusion and inclusion criteria, we had about 6,200 patients who had a mean blood lead level of 1.6, so that is not elevated, about 2 tests. The average age was about 2.5, roughly male, well, half were male, and then 44% were Hispanic or Latine, and 30% Black, non-Hispanic or Latine. When we look at the population that had a positive lead test, about 2% of our population had a positive result. And among those children, we see that they had an elevated lead level of around 4.5, had an average of 4 tests, and they were more children were male and Black compared to the overall population. Here is a map I created of our study population. For confidentiality, the dots are randomized within the neighborhood, so you cannot zoom in and find somebody you know. But we see that the majority of our population is within the neighborhoods of Dorchester, Roxbury, and Mattapan, where we also see a much higher of the yellow dots, which indicates a child tested positive for lead. Our first measure is the Child Opportunity Index. And this measure, again, can come on the national level, the state level, or the metropolitan level. But in areas such as Boston, where there may be concentrated disadvantage, it's helpful to even go down to the city level. So we took the metropolitan level and made our own Boston-specific Child Opportunity Index. So all the neighborhoods are compared within the Boston context. For our individual analyses, we took the COI level of the patient's first lab visit, and then for the block group, we took the 2022 COI level, which covers the majority of our study time population. When we look at the COI within our study population, overall, the levels are about the same within those who have a positive value and those who are in the population, with the majority of our sample being either in the low or very low categories by the blue boxes on the right. When we look at 311 reported housing complaints, we first grouped complaints related to housing under what we called healthy home categories. Again, referring back to our framework, which includes cleanliness or safety concerns, pests or rodents, or even a lack of utilities. We are connecting this to tenants in particular because a tenant may be more likely to use 311 to report a complaint on their landlord. And so to have that understanding, we made a complaint rate by taking the number of housing complaints within a block group, dividing it by the renter population within that neighborhood. We did this for the entire city of Boston, broken up into categories or quartiles, then assigned those quartiles to our study population. By doing that, we see that overall, about 33% of the population are within the highest burden category. And we look at children with lead, about 47% of them are in this highest complaint burden category. The outcome, again, was elevated blood lead levels. And during the study period, the Centers for Disease Control changed the reference value for what constitutes an elevated blood lead level. So we took that information to give the proper metric for that particular part of our study population. And again, for individuals, we're looking at if they had at least one positive lead test. And then for the neighborhood or the block group level, we are looking at what was the rate of positive tests among children in our study population. Go through our statistical analyses briefly for Rachel. And so for our individual model, we use multivariate logistic regression and also use robust standard areas to account for clustering at the block group level. And these were our covariates for that model. For the block group, we did a negative binomial regression because we're looking at the count of children who have a positive test, and we adjusted for housing age. So for housing age, we use housing built before 1950. Now you may ask, why 1950 if 1978 is when the law was changed? Well, the earliest indication within the United States of some type of lead regulation happening was in the 1950s. So this is the most protective measure to look at old housing. For our sensitivity analysis, we want to look at a potential mechanism to which housing complaints could be related to lead exposure. So we only looked at complaints that may deal with something structural in the home, which are listed there. This is the model for our effect modification. We'll come back to if you have questions. So when looking at our results, these are two forest plots of the association of the neighborhood characteristics and our lead outcomes. So per Dr. NB, the way that you can read this, yes, ma'am. The way that you can read this is the dashed line at the 1 represents our null. So any blue dot or black dot that is above that is either we may expect to see some type of actual association taking place. So when we look at our results, when looking at the individual level associations, we see that the third category for the neighborhood complaints, we see us children were more significantly likely to have an elevated blood lead level. And then on the neighborhood side, they were more likely to, the neighborhood was likely to have a higher positivity rate. When we look at COI, we did not see a significant relationship for the low or the very low categories. But when we look at our effect modification, we see that on the left, neighborhoods that were identified as being very low COI, when we look at how housing increases by 10%, we see that in the very low category, the lead risk is increasing, but for the very high/high group, it is not increasing. So we see an inverse relationship based off the COI. And we see the same thing with the block group level, but our association was not officially significant. So in conclusion for this particular aim, we saw consistent associations at the block group level between housing complaint burden and elevated blood lead levels. With the structural complaints, I did not show this model, but those models mirrored the same ones as the primary analysis, which was a mechanism to lead exposure. We're looking at our effect measure modification. We see that COI potentially modified that relationship with as housing age increased in the very low groups, lead risk increased for those individuals, which can speak to the burden of environmental hazards within those particular areas. And as a note, I will discuss limitations and strengths for all the papers at the very end. So our second aim, moving on swiftly, we're looking at thresholds of burden, and this project is entitled 311 Tenant-Reported Asthma Triggers Signal Pediatric Emergency Department Visits for Asthma. And this is a time-stratified case crossover study. So there's a need for proactive surveillance before an asthma exacerbation event occurs, because asthma is one of the leading causes of pediatric ED visits. This can also, as we mentioned, vary by structural neighborhood opportunity, where we may see that an acute trigger exposure in a home with the underlying biological susceptibility, when those two things combine, we may see a rapid worsening of a child's symptoms over a short period of time. However, current surveillance mechanisms will look at clinical encounters after they had occurred. So the question is there a way to kind of signal what may happen before they even get to the ED? One proxy for this is, again, our housing complaints, which research by Adam Haber and his team, along with collaboration with Dr. Hartman and Dr. Adamkowitz, they found that 311 housing complaints were related to asthma ED visits in both children and adults. I'm extending that work by looking at how early in advance is a call made? Do we see a relationship with these potential ED visits? As this temporal relationship could point to leveraging city data to support prevention efforts. Again, the hypothesis for this aim is that as the number of housing complaints, particularly asthma trigger housing complaints, increase within a block group days before the ED visit, it will be related to subsequent asthma-related ED visits. We also look at how this changes by the complaint type. So if someone's calling about there's roaches in my home or I don't have proper heat, how may that relate to this relationship? We then looked at how the COI modifies it to look at potential structural disparities. And we hypothesized that these neighborhoods in lower COIs, we may see a longer range before they go to the ED. So let's say, for instance, if the overall population, you may expect 2 days before, in these neighborhoods, you may see a week and a half before. Our study population for this aim we are looking at emergency department patients at Boston Children's Hospital who have an asthma diagnosis. So every child already has asthma. And we are looking at ED visits in which they went for asthma exacerbation between January 2018 and December 2024. This resulted in a sample size of about 3,300 patients with little under 5,900 ED visits. And we have the summary of their statistics here. Some things to note is that 41% of this population had a very low COI. Again, we're looking at our 311 data. We are looking at the number of asthma-related housing complaints in the patient's block group each day. And we categorize this by the healthy home categories, but are only looking at asthma-related categories based off the work done by Adam Haber's team, which are these 5 here. Our asthma-related ED, oh, y'all want to look? Yep. Oh, okay, there you go. For our outcome, again, looking at asthma-related ED visits, we define this as ICD-10 codes that are consistent with asthma exacerbation, or the child was administered a short-term beta agonist during their visit. And any ED encounter that was separated by less than 8 hours, we considered a part of the same visit. 60% of the ED visits were asthma-related. So for our statistical analysis, again, we use what's called a time-stratified case crossover approach. So put simply, this is a method that allows us to evaluate short-term associations between acute exposures and acute outcomes. So with our graphic here, we are interested in asthma-related ED visits. We are comparing the 311 activity during normal times compared to the time right before this ED event to see does 311 activity change right before the ED visit? Because again, this is a proxy for neighborhood environmental exposure. For our exposure, we looked at a lag of 0 to 7 days individually. And we also looked at cumulative lag periods of 1 to 3 days, 1 to 5 days, and 1 to 7 days. For our primary analysis, we excluded any control days that were also an ED visit for that child. Our covariates, so with this type of statistical model, we do not have to control for what we call time invariant covariates. So that essentially means something that will not change from today till tomorrow. I will still be me in terms of my age, my sex, my gender tomorrow. So we do not have to adjust for those factors. But things that do change, such as air pollution and temperature, we do adjust for that. And then for our COI measure, we again look at our Boston specific measure, combining the very high and high categories. And this is the model for our effect modification. And the model for our sensitivity analyses. So we conducted 2 different sensitivity analyses, one being having all the control days for a patient, and then having a washout period in which we do not consider the 7 days following the ED visit, because that would include the case day. So trying to control for potential reverse temporality. So when we look at the association of our lag 311 complaints and asthma-related ED visits, again, 0 to 7 is each individual day. We see that for the overall population, each additional 311 complaint on a given day was associated with 1.28 times the odds of an ED visit the following day, compared with the other time periods of that child. When we break this down by childhood opportunity index, we see that for the low and the very low child opportunity groups, we see that relationship. For the low group, we also see a signal at the 7-day mark. When looking at this lower COI group, we also see that for each of our cumulative lag periods, they had a significant relationship. We also, again, broke down our analyses within the 1-day lag, looking at each of our complaint types. And we see that for the moisture complaint types and the pest complaint types, it is suggestive of a relationship at that lag day. I gotta hurry up, my bad, y'all. So in discussion for this particular aim, we see that the short-term lag which is a 1 day lag, was associated with an ED visit the following day. Now you may be saying, why only 1 day? There are two potential mechanisms that could be taking place. One is a biological one. So as a family maybe have mold and pest allergens in the home, as those exposure to those particular animals increase or those allergens increase, the child's symptoms may worsen rapidly over time. And this may happen at the same time they call that I have a complaint, right when the child may go to the ED visit. So it's happening close to each other. And this may be why we see a signal for the moisture and the pest complaint types. When we look at a behavior mechanism, as these conditions worsen and as the child's symptoms worsen, the parent may say, I can't take this anymore. And then we report around the same time the child ends up having an ED visit. The fact that we see that for the lower opportunity childhood groups that the lag extends up to a week, we could be seeing a manifestation of structural inequities. So the fact that it is a much sustained association shows that they're experiencing these conditions much earlier. All right, now going to our third aim. For this one, we look at how environmental trigger exposure is associated with asthma-related ED visits, hospitalizations, and costs in a community asthma initiative. And this particular project was done with the Community Asthma Initiative at Boston Children's Hospital, known as CAI. For this aim, there is a need to understand baseline environmental exposure. ED visits and inpatient hospitalizations are key drivers of asthma-related costs, estimated to be about $8.92 billion in 2026 dollars. Community-based programs such as the CAI is intentional in addressing asthma disparities and social needs. And based off their work, we have seen improvements both clinically and economically in terms of children's healthcare outcomes. However, we do not know the relationship between the baseline environmental burden and subsequent healthcare. And the reason why baseline is particularly important is that when a child enters into the program, they may have different severity levels of their asthma. So if we see how this severity level of their asthma could relate to potential healthcare usage down the line, we are able to then, oh, I had no other slides. We are then able to just give the motivation for intervening on these particular environmental exposures. For this aim, we are hypothesizing that baseline environmental exposure is related to subsequent ED visits, hospitalizations, and associated costs for these two particular outcomes after they are in the intervention. So we're looking at underlying susceptibility even after they are in the program. We also stratify this by baseline asthma severity to get at that differences in asthma risk as relates to our outcome. Our study population were participants who were in the CAI, and they were in the program. They were enrolled from January 2013 to December 2023. Very briefly, patients are identified based off their healthcare utilization, and that being asthma-related ED visits, inpatient hospitalizations, or had 2 or more prescriptions for oral corticosteroids within the previous year of being enrolled in the program. They were also enrolled if their primary care provider or asthma specialist referred them. After they joined the program, the participants will undergo both home visits and asthma education. And then following these home visits, they are followed up with at the 6-month mark and 12-month mark post-intervention to assess their asthma morbidity and management. We had about 525 participants with an average age of about 6.5 and a mean environmental severity score of 1.92. And I'll explain that on the following slide. Something else to note is that during the CAI, there were 3 different phases. 2 phases occurred pre-COVID, and another phase occurred during COVID, in which the program changed some of their methods to meet the patients. So 81% of the population were enrolled before COVID. Our exposure metric is called the environmental severity score. And this is a sum of 6 binary indicators that is based off the community health worker's observation and self-reported by the parent of potential trigger exposures. So this ESS was created based on prior work of people such as Gary and other individuals at the Massachusetts Department of Health. And when we look at these 6 different indicators, we see that within our population, over half had at least 1 to 2 of these indicators. Our outcome, again, is ED visit, hospitalization, and associated costs with those 2 particular health outcomes. So we received the ED visit and hospitalization information from the CAI program data. Again, this was parental self-report of if the child had one of these 2 outcomes within the last 4 weeks before the follow-up occurred. And this happened at the 6-month mark and the 12-month mark. And we took the latest follow-up information that was available for a participant. For the claims data, for the cost data, we got that from Children's Hospital claims data, in which we looked at the total asthma-related ED and hospitalization costs 6 to 12 months post-intervention. So these costs include department level and overhead expenses, but exclude pharmacy costs and physician expenses. And importantly, at the hospital, charges for hospitalizations are bundled with the associated ED visit. So what that means is if a child has a hospitalization within that cost, if they had an ED visit, it is wrapped up into one. You cannot break them apart. When we look at the percentage of participants who had one of these outcomes, this is good for the program success. We see that most of them did not have an outcome following their participation within the program, as evidenced by the low percentage values. However, when we look at patients who did have a healthcare cost, we see that children who had an ESS of 3 or higher have a much higher median baseline cost and a larger spread of what those costs could be. Again, some patients having a cost over $150,000. For our analysis, for the ED visits and hospitalizations, we use logistic regression, looking at the likelihood if either one of those events occurred. And then for our cost, we modeled it using what's called a Tweety regression, not Tweety Bird, just Tweety. And so our cost measure is what we call a semi-continuous outcome. And what that means is the majority of participants may not have a cost. And then for the few that do have a cost, it may be a right tail skew or extremely very large. So this model allows us to model both of those things at the same time. We then did a predicted means to try to get a real dollar amount as to what could be taking place with these methods here. And a sensitivity analysis only looking at those at the 12-month follow-up period. So in looking at our associations between baseline environmental score and our health outcomes, we see that participants who had an ESS of 1 to 2 had 2.24 times a higher likelihood of having an ED visit at the 6-month or the 12-month mark. But this is marginally significant. What we're really interested in is the cost piece. And we see that those patients who had an associated ED or hospitalization costs, those participants with a score of 3 or more had 2.3 times higher the cost compared to those who did not have any environmental triggers. When we look at the predicted annual mean at each baseline category, we see that there's about a $2,100 difference in our predicted model for those who did have an ESS of 3 or more compared to those who did not have an ESS at all. And when we stratify by baseline asthma severity, we see that the predicted cost followed a graded pattern within each severity level, with the increase across ESS being more pronounced in participants with higher severity levels, as indicated by the blue line. So in conclusion, participants with an ESS of 3 or more have significantly higher ED and hospitalization costs independent of disease severity, which means that costs could reflect both frequency and intensity of care. Again, our ED and hospitalization measures were self-reported, but the costs can both indicate how many ED visits you had, how severe it was, and how long you may have had to be in the hospital. We also see that costs were more pronounced for those individuals at higher baseline asthma severity across the categories. and to note that these may be underestimates of the full economic burden because we're only looking at ED visits and hospitalizations. And these families, again, are living in their built environment with so many other factors. We're almost there. All right. So in conclusion, the opportunity to act, courtesy of my other nieces and nephews. So again, to summarize our dissertation findings, for our first aim, we see that greater 311 housing complaint is related to increased pediatric lead risk at both the neighborhood and the individual level. For our second aim, we see that there are short-term increases in 311 asthma triggers are related to pediatric asthma events after. And then for our third aim, we see that higher baseline environmental exposure is related to increased asthma-related ED visits costs. So a few going over our limitations and strengths. First is selection bias. I will go through these quickly because I know I have questions on it. But for the first aim, again, we are looking at patients who received a lead test. So there may be some patients who did not receive a lead test. However, in the state of Massachusetts, all children are required to have a lead test between the ages of 0 to 3. So, and then for our third aim, there was loss to follow up, but the overall population was very similar in terms of demographics to our study population. We may also have exposure and outcome misclassification. Again, when we look at 311 data, this is individuals doing it. So there's behaviors involved. When we typically think about 311 in the literature, we may think there's an underreporting in lower income or racialized identity neighborhoods. However, research has shown that in Boston, African American neighborhoods may actually have a higher rate to report 311 compared to other ethnic groups. So this is just to say it's very complex and we should do more studies to figure out that relationship. We mentioned also that we tried to adjust for reverse temporality, but that is still a concern because in some of our sensitivity analyses, we saw it light up, so to speak, the day the child went to the ED. And then generalizability. Again, we are only looking at Boston Children's Hospital. It is the largest pediatric unit within the greater Boston area, but I'll leave it at that. We also localized our COI to Boston, which means it may not be applicable, let's say to Cleveland or to Augusta. But these methods can be very applicable to these other locales. Some strengths of our study is the statistical approach that we took, as well as our data sources and the applicability for addressing environmental burdens in communities. So I will briefly go through these for time's sake, but I wanted to be very intentional, as Gary said, what could we do with this information? So on the practice side, there has been some research again at Northeastern University of using 311 data to inform different social outcomes. This could be extended also into the healthcare space. Also, hospitals such as Boston Children's and even Mount Sinai have health screeners that also consider social determinants of health. We could use the COI in those type of models. And then investing in environmental remediations could also be beneficial. On the policy side, cities can take what's called a health in all policies approach, which is how does the health of our community change based on what we may do or may not do, as well as strengthen processes for remediation enforcement within cities. And finally, on the research side, which applies to a lot of us, this is a very quantitative study, but there are other types of studies that we can get at to understand what is happening in terms of the lived experience, but potential solutions to that problem. And I'll actually go through some of the work I've done that kind of fits into these three different buckets. So as Gary mentioned before coming to Harvard, I worked in New York City for the Region 2 Pediatric Environmental Unit. And while there, I was the program lead, what's called Prescriptions for Prevention. So this was a clinical tool that will connect families to environmental resources beyond the clinical space. While here at Harvard, I also, thanks to the FXB Center, thank you, Dr. Bassett, I was an environmental justice scholar at Boston Children's, and we looked at other ways to improve the healthcare of patients. I've also been involved with the Center for the Developing Child and the Early Childhood Scientific Council on Equity and the Environment. And with my work with the council, also with Dr. Slopin, we have produced 4 different working papers that connects environmental concerns to broader policy implications. I also was able to present to youth for their climate change summit because, again, youth are both the present and the future. So having them involved with this work is important. Speaking of youth, I will always be a big kid. And so thanks to Dr. James Todd and the Harvard Presidential Public Service Fellowship, I served as a mentor for a community summer camp that was geared towards Black children who are in elementary school and middle school. And it was featured, oh, thank you, Uncle. This was also featured in the Harvard Gazette. I also did a course at MIT in which we worked with students in Philadelphia, teaching them about their environment and to help them create an urban garden plan. And finally, I have some passion projects that are on the side. And one of my passion projects is how do we connect faith-based communities to this work, and particularly within my own faith tradition, which is Pentecostalism. So some of the work that I'm doing is, again, this is completely side passion project, but I've done an historical analysis of Black Pentecostal engagement in the built environment and connected to environmental justice. Also, I am a John Lewis Fellow with the Faith and Politics Institute, and I conducted an oral history with one of the leaders within our church, looking at his social justice history as it relates to how it could inform the church's work as well. So in conclusion, by looking at my aim 1, aim 2, and aim 3, we can help make sure that we have healthy homes and healthy kids no matter where they live. Thank you. You get a thank you. You get a thank you. Everybody get a thank you. Woo! I gotta say first, Lord, I thank you. And I'll leave that there. But I want to thank viewers like you, because as Kamala said, we did it, Joe. We did it. I appreciate all of you. I would like to thank my dissertation advisory committee. First, I have to thank Gary, who is our expert on the environmental health exposure assessment, and my primary advisor, Gary. I thank you truly for letting me be me. I know there are many advisors who kind of hold their students on a leash. I'm not supposed to cry. What's happening? But who can hold their students on a leash, but you've given me the ability to make sure my work is done, but to explore all these other interests. And I think that's made me a better scholar and a student. I thank you for that. Marissa, I am honored to be your first official PhD student. Nobody else will have that distinction, and I'm honored to be the first. Again, she is the expert on geospatial and pediatric environmental health. And for me, I was very intentional in wanting to continue the work I did in New York City. And you just open your arms, you and Alan, everyone, to allow that to happen. And you're sweet and you're kind. And I appreciate that. Natalie, she is our expert on the social and behavioral sciences, which is one of my majors. We joke with my friends that, am I really in environmental health? Because I do so much on the SBS side, but I am. And Natalie, just thank you again for your kindness and even introducing me to the Center for the Developing Child. She emailed me randomly, hey, would you like to work with us? And I'm working with them 3-4 years later. And then Rachel, our other Southerner in the house. Thank you for, again, providing your kind, but your wisdom in terms of biostats, because none of this is important, but this is important work, but it doesn't matter if your math ain't right. And you made sure the math was right. I'd like to also thank our collaborators. Emily, I could not find a picture of you. I was looking. Well, I'd like to thank the COI team. They actually gave us early access to the Childhood Opportunity Index on the block group level. So if you go online, you can get it on the census tract level, but thanks to Natalie's connection, we got it on really the neighborhood level. And then to the CAI team, to Dr. Liz, Dr. Faye, Emily, to everyone. When I was a first year, I did a paper on the Community Asthma Initiative. And I said, you know what? I want to work with them. And here we are a few years later, able to do a work that I feel has been very impactful and meaningful in a very applicable manner. I also have to thank my New York family and my Baltimore family. The reason that I became involved within the environmental health space is based off an internship 9 years ago at Mount Sinai. And I was a student there. As a student, I interned and I worked with them. And now they're saying to come back. I'm gonna do my best just to help everybody out. But thanks again to Maida, to Perry, to Lauren, to Terry, to Chris, to everybody up there, because you're why I'm in environmental health. And then I have to mention the Diversity Summer Internship Program, because I was someone who said, I will never do a PhD. I will never do research, because I felt that the work did not truly matter for community members. I felt that they only write for papers, they don't do anything. But I learned that that was very narrow-minded. Research can come in a number of forms, and they helped me see that. And again, thanks to the Spatial RX and the PASU team here in Boston, I appreciate y'all. Got to give a shout out to the PHS cohort. We made it and we're making it. We're doing it. We have a few pictures here and there. I have to give a special shout out to Hannah and to Marche. Those have been some of the road dogs, and Marche is now Dr. Marche as of Monday. So we will meet up just to go to some crowd ball places or bike or just talk about Harvard in all of its many forms. And I have to give a special shout out to Taylor as well. We actually lived in the residence halls our first year, and we also just constantly collaborating. She was like, "You got it, Joe. Keep going, Joe." So I appreciate your support. Keeping it moving. I've been outside of Boston. I'm really very involved in Cambridge and multiple communities. One is with the faith community. So I have to give a shout out to the Graduate School Christian Fellowship just for their support. And then also to my Soul Food family. So Soul Food is the Black undergrad Christian Fellowship. And I've been allowed to volunteer with them the last 4 years. And while they tell me I'm onk, I still feel young. And they've allowed me just to be in their space and to be one of them. So I appreciate that. I am also a resident advisor on the side. So I have to give a shout out to the RA team, both this year, last year. Thank you, Becky, for being here. It's one of my supervisors. And it's been fun. It's been a good distraction from Longwood in every sense of the way. But I appreciate all of y'all. And these are my homies, truly. I call them the heartbeat of Harvard. I've always been blessed to have a connection with the staff at any place I go to. And whether it's been the custodial staff here at Chan or really where I live in Cambridge, they truly have been a blessing to me. Each day I go, "What's up, everybody?" Just start talking with them, making jokes. And it reminds you that yes, we are students, but we are people first. And connecting to people wherever they are truly matters. And I've been able to do that. I've got to give a shout out to my church family. Oh, wow. Y'all have been a blessing in every sense of the word. My Cool JC family in the house, Region 1, everybody, I love y'all. Dr. Derek, he's also a doctor. Appreciate you. But again, being able to be in a space where I could not only be myself, but grow in my faith and grow in community has just been amazing. I have to give a shout out to this family here, the Ramsey family, Trish and Craig. Y'all know how I feel about y'all. Auntie Mel, Rambo, Nick, Dana, everybody. That's been my home away from home. There have been times in which on a Saturday night, I would fly from Georgia, Sunday night be in their house eating some pork chops because I'm with the family. And everybody listed here, even our late apostle who passed away last year, they've really been influential in my life. My non-Boston family, I started going through my photos and I had to stop adding pictures because we would have been here all day. But these are people from my time at Williams College, people from high school, from middle school, and even friends I really made a few months ago. Shout out to my FPI family. Even church friends. No matter where they've been, y'all have really been my rock. And one of my aunts said that people say they have a village, you have a country. And I truly have a country in every sense of the word, and I'm grateful for that because that's love. And then speaking of love, I have my family. This is my, I guess, extended family, but we don't even use the word extended. It's the fam. So many people on here are my biological relatives, but some are not. One person there, that's my teacher from high school. That's Auntie Millicent. I have my best bros, Chris and Paul. Bros, I love y'all. Thank y'all for everything. And then even my bro Malik, I had officiated his wedding a few years ago. So again, community exists beyond these spaces, and I'm just so grateful to have all these people in my corner. And last but not least, got to thank my immediate family, the Wilsons. We are a fun group, as you can tell. There was okay, we know it's you, right? Yeah. Again, I'm the oldest, I said, of 7. I'm the second oldest of 31 grandchildren, 6 great grandchildren. And it's never been a quiet moment in the house, but those are always moments of love. My mother is here in person, and as my my mother worked 3 extra days so she could take off to be here. And as I say, that is my twin. Like people are saying we look like we're siblings, and that's okay. That means she looked young and I don't look old. But both her and my father, I'm his namesake, I'm a junior. They have just been godly examples of what it means to love the Lord, to love your family, and to do your best. To my siblings, to Stevie, to Sean, to Jalen, those are the ones who grew up immediately next to me. I love y'all. And then for my younger siblings, Sam, Josh, and Promise, y'all just keep growing up and making your big brother proud. And then in conclusion, I've dedicated this dissertation to my nieces and my nephews. And this is both my biological family and my chosen family. Again, I am someone who does not know family by any distinct bounds. So while I have my nephew AJ, who is my twin, my nephew Asaya, Elijah, and Tiana, which are my sister and brother's children, since being in Boston, I've gained nieces and nephews. Craig and Trish's daughter is right there. We have little Mila. We have Bianca's baby who works here at the School of Public Health. We have just so many people and these are my nieces and nephews. They call me Uncle Joe. I'll discipline them if I need to. But it's a good time, and they are the future. And then last but not least, I want to do this in honor of my aunt. Man. So my aunt passed away 6 years ago of last week from COVID, and she was 30 years old, and I'll be 30 next year. And when I say this was like my road dog, this was my road dog. My sister and I were joking last week saying that if she was listening to me talk, she's like, boy, be quiet, you're talking too long. Like, okay, we get it, you're a nerd. But she was someone who had the sweetest heart, the sweetest smile, and that was my buddy. She wasn't just my aunt, that was my friend. And I know she'll be here, she could have been, but I love you, Auntie. And so that's all, folks. Okay, now for the question.